Hi, everybody. It's Karen Anderson with Aortic Hope. It's been a bit since we've done our last live event, but we are back and we have Dr. Stacy Fisher with us tonight, cardiologist, my cardiologist. It's always exciting when I get to do that. And she's here with us and we're going to talk about a couple different topics, and that's typically the format. We're going to talk first, and then if you have questions, please type them in. We're going to try to get to as many as we can tonight. And then, of course, whatever we can't get to, she has access to our page and can write responses to you. Remember, it is an open page, so if you'd like to ask an anonymous question, just send the message to Aortic Hope as I am scrolling that on the phone right now, and we'll try to get to those as well. So, hi.
Hi, thank you for having me.
And you're part of the Aortic Disease Center at the University of Maryland, right?
Absolutely.
So do you want to tell them a little bit about that? Because there's centers popping up, and not everybody has a center near where they live. And what's the benefit of doing that?
Sure, the benefit of having and using a center is that you have multiple impressions, thoughts, backgrounds together, and resources. So for example, one of the things that many centers don't have is genetics. A vascular surgeon with a thoracic surgeon or a cardiothoracic surgeon preferably together. You have the interventional people with the surgeons, so that if there's options to do things with catheter-based technology instead of surgery, that's obviously going to be preferable and an easier recovery if you think that you can get an equal outcome. But also having the medical people with the surgical people sit around a table, discuss your case, review your studies, and look at all the different options that are available. You can get a lot of information from one visit, one group, one recommendation. And that's really what led to making a center and what a center is all about.
Do you guys sit around and talk about me?
Sometimes.
Dr. Kelly.
only when you have scans.
Right, when my scans come up, yeah.
And it's more like, Karen feels well, is doing well, had these labs, this is the scans that she's had, this is the dates of her scans, this is her genetics, where do we want to go, what does she need, what do we want to do, what kind of schedule.
Okay.
And then we move forward with recommending that to you versus Sam, for example, who's a made-up person. Sam isn't feeling well. His right leg is going numb when he's walking. He's having a lot of hip pain. His scan actually shows extension of his dissection. Everything is below the abdomen. We really need impressions from the vascular person as it's below the level of the chest, versus somebody else is having trouble in the middle part that involves the chest and the abdomen, and may have a vessel that's having difficulty that supplies one of the valves, or one of the bowel aspects of the bowel. Or, for example, we have a patient who has Marfan syndrome who just delivered a baby who has a new type B dissection a week after delivery. And, who do we need involved? How can we manage this, hopefully conservatively? What types of treatments of follow-up and schedule does she need? That's a very different answer. Can she continue breastfeeding, for example? A very different question. We're bringing into this center, we need to bring the OB group in.
And you just brought up a really good point that sparked a question that we've heard about online. Some people have said, do you see your surgeon for follow-up care? Is it your cardiologist? And if it is a surgeon, is it thoracic? Is it the one who did surgery if you had a dissection? Or is it vascular? Or do you need all three to be part of your plan? So what does really, let's say you had a type A dissection versus type B. So you, of course, have met your surgeon. What's the best route for follow-up care? And what are the different things that you all do that make up the team?
So that is a really important question, and the answer is going to be different. You have people that are in different countries, different areas of our country where access is different. So it may be that in your center, the best person to do your serial follow-up is your cardiologist versus your cardiac surgeon versus your vascular surgeon. So if you have a type A dissection or aneurysm, you're going to want the cardiac surgeon to actually be the primary person. Now, if that's been repaired and the repair is intact, the cardiac surgeon may actually sign off and just give a recommendation to the cardiologist for, I'd like scans at this interval, and if you're seeing changes in the scans or there's any concerns, then I want to see the patient again. But many of the cardiac surgeons actually just see people right after the surgery course completes and then sign off and let you go back to the medical team for blood pressure management, for screening, for serial assessments. And if there are changes, you would see that person. At the same time, unless it's a bicuspid aortic valve issue where the only thing at risk is the ascending aorta, or sometimes we screen for something called a berry aneurysm in the brain. Unless it's that, many of the different syndromes or gene changes, actually, we recommend screening of the whole aorta. So if we're seeing changes in other areas like the abdomen or outside of the chest, you might want a vascular surgeon, or in some parts of the country, interventional radiology or interventional cardiology. So you would have your cardiologist actually look and see who the team is that you need assembled for your particular site, problem, genotype, and you want to have a care team defined.
Now, you've brought up genetics quite a few times, and this is always something that's of deep interest to everybody out there. Talk a little bit about what, who would qualify to have genetics, at what point, would that be with aneurysm, strictly after a dissection? When does bringing in genetics or having a cardiologist that specializes in genetics, or if you don't, how do you get genetics? So the when, whys, hows of genetics involved with aortic disease.
So that's actually a huge topic, and one that I love.
I know that you do.
So if you have really bad hypertension, for example, and you're 80 years old and you have plaque everywhere and you've had a tear, it's clearly related to the plaque and the blood pressure, and that may run in your family. Generally, it would be at an older age, and it would be plaque related. So that's probably the most common issue of aneurysm and dissection, and that does not require genetic assessment. It requires treatment of the underlying risk factors, the cholesterol, the blood pressure, the blood sugar. If you have a strong family history of aneurysm or dissection, that's not explained by just blood pressure and plaque. That's actually the perfect time to add in the genetics. If you have a family history of anything that has more of a syndrome and musculoskeletal or connective tissue problems, that's a wonderful place to add the genetics in. And if you can actually explain why this happened, you can have a much better understanding of, is your family at risk? Who needs screening in your family? How can you prevent this problem or sudden death in a family member and someone that you love? And you can use that as a gift to your family to prevent a tear, right, or a rupture. Yeah. So it can be really important as a gift to give that genetic testing. For yourself, though, it may actually change things in a way that changes your own health. So, for example, a lot of the screening and testing that's being done is something that can be changed or personalized for you. So, for example, if you have a particular gene, I'm sorry, I'll just be 1 second.
The life of a doctor.
Hi, can I call you back?
If you need to take it, I can get
I'll just be 1 second.
Okay, so here's some filler. So some of the things we're going to also talk about would be the likelihood of a dissection or an aneurysm just forming. What does it mean if it forms in the abdominal area versus thoracic? Some of the other topics I've heard you guys talk about wanting to discuss would be, why are some people prescribed cardiac rehab and others are not? And if you're not prescribed cardiac rehab because it's not covered by insurance, what are some alternative ways that you can help rehabilitate yourself after having a dissection? So now is a really super great time that if you have questions, before Dr. Fisher comes back in, start thinking of them now, or a topic you'd like us to talk about, questions you'd like us to answer. I know one of the hot topics for the community always is discussing blood pressure medications, side effects, how do they work, when do they work, and why are certain ones chosen, and what are the benefits for using some of these medications. So we're going to talk a little bit about that. And what else can we talk about? I want to show you guys something because it doesn't have a patient's name. So I was in here the other day with my son getting his echo, which that's a whole other story. I was a little surprised by the results. And the woman who does the echo here said that one time there was a patient that came in, and I don't know if you can see this, but this is the aortic valve. This is an ascending aneurysm. This is the point of the valsalva right there. Can you look at this? This is about 7 to 8 centimeters big. Can you imagine being the technician that decides to put a wand on a patient and you see this huge, I can't do it backwards, huge aneurysm? Typically it would be like maybe about the size of this, but this huge, and that's a huge aneurysm. We were talking about that the other day. It's pretty exciting. So she's just finishing up her call. What other fillers can I give you guys for a minute? Oh yeah, so here's an interesting story. So I did bring my son in to get his baseline echo, and he's a big kid. He's like 6'3", 260 pounds, and yeah, he has to lose a little bit of weight. But his ascending area was a little enlarged. Oh, I think she's coming back. I'll share that story with you later. We'll go back to, I showed them the picture.
Oh, good.
Yeah, it was pretty exciting.
Did you show them what it is?
I did. I went over the anatomy, but you can go ahead and do it.
Yeah, so this was actually a patient of mine. She was 95 years old when she had the study done. This is her left ventricle here. And she had had a bicuspid aortic valve. I have to do this backwards.
I know, right?
She had a bicuspid aortic valve replaced. So this here is an artificial aortic valve. And then this is her aneurysm.
So big.
Sorry, from here. Yeah. And that aneurysm is about 9 to 10 centimeters.
Yeah.
She was 95 years old. She decided not to have surgery. I don't know whether it was good or not that we actually found this, because she felt like a ticking time bomb. Mm-hmm. She also had a fantastic attitude, though, and lived another 5 years with that without rupture, dying of other things.
Yeah.
Was actually active, was able to travel and visit her family some, and really had a good quality of life. We think that she actually didn't rupture. She had a contained rupture, but she didn't rupture completely. Because of the previous surgery, she had some scar tissue around the aorta that seemed to be holding the rupture contained. Back to the genetics.
Yeah.
Sorry. So as far as the genetics, there is a lot of research going into collagen as well. So we really are hoping that by understanding particular gene changes over time, there will actually be genetic therapies that can be given. So for example, if you have a gene that makes a certain protein and your collagen is weak because you don't have that particular aspect of the protein, if we could replace that protein and have it work within the cells to strengthen the walls, we could potentially reverse the risk of aortic dilation, aneurysm, or rupture in certain people. So if you're one of the people that has been tested and has those gene changes, you would be first line to get offered these therapies and to actually have available the therapies that may be helpful. We also understand better which ones may have associations with rupture, for example, in the brain, in the abdomen, in the legs, who needs more extensive screening, who's actually at lower risk of screening of aneurysm in other parts of the aorta where you may not need all of the screening. And then you have syndromes like Marfan syndrome, where you also may have issues with the skeletal system, with connective tissue in the joints, in the ligaments and tendons, things that can change your physical therapy, your rehab, things that can change the way that you approach your recovery, even if the way the surgeon approaches the chest wall, or the way the surgeon handles the rest of the aorta, how fragile the aorta is in other places.
So if you're just joining us, this is Dr. Stacy Fisher, cardiologist, my cardiologist. I'm saying that. We're talking a variety of things tonight. Any topics that you're interested in, I'm going to start scrolling down and any questions you have. But another thing I mentioned to you when I came in the room was cardiac rehab. And not everybody is offered an opportunity to take cardiac rehab, whether that's covered or not. I think we've heard people say that the insurance said, we just don't do it for dissections. And so if they're not allowed that, what do you think would be appropriate, if anything, after having their aneurysm fixed or dissection or what have you?
So currently the only covered, always covered programs for cardiac rehab by Medicare, and many of the insurances use Medicare as the guideline that they go by, are people that have had heart attack, bypass surgery, have stable angina, and now they've just added heart failure. So before the last 2 years, we couldn't even get people covered that had heart failure trying to avoid transplant.
Wow.
Or post-transplant, to be honest. So this has been an ongoing issue where we're trying to expand cardiac rehab and make it more available. Often if the heart valve has been replaced or the heart function has been decreased, the cardiac rehab can get covered much better. We can certainly make a plea to do it after aortic surgery, and sometimes it gets through. I'm sure some of you have been offered cardiac rehab, but it's definitely not guaranteed. So what cardiac rehab is, it's generally 36 exercise sessions where you're monitored. You're on a telemetry monitor looking at the rhythms. Your blood pressure is checked before, during, and after exercise by a nurse. There's a physical therapist or nurse that guides your recovery so that your exercise is adjusted by your heart rate, your own blood pressure, and your rhythms. So what you can do if you do not have access to rehab depends on your functional state. So if you're really struggling in your recovery, you feel imbalanced or weak or tired, often physical therapy will be covered. And that can be something that's done at home with home physical therapy visits. And then if in fact you have needs, for example, your balance is off, or you're not able to get up and down the stairs well, or you're not transferring well between, the toilet and the shower, then you can generally get sessions first at home and then at the end of the home sessions at a physical therapy center. But physical therapy is also limited and is focused on particular problems like your back or your knee or your balance. And once you meet the goals or come to a stall, meaning that you're not showing progress, then the physical therapy insurance coverage ends.
Right.
So it's a time-limited thing. If you are stronger and maybe had a great functional capacity going into your surgery, then you may actually not qualify for physical therapy either, in which case it's probably best to just start with a walking program. Walk with somebody, take 5-minute walks 3 times a day to start with. Work your way to where you can do 30 minutes at a time, not a pressured or exercise walk initially, but a comfortable walk where you can speak a short sentence through. That's a good level to push for. And when you're comfortable and your pain's controlled and you're doing well, then you want to start pushing yourself a little more incline, a little more pressure, a little more walking. And then once you're off of the sternal precautions, you can start rebuilding with 1, 2, and 5 pound weights, trying to rebuild the chest muscles to get the chest muscles stronger and start working toward a more comfortable experience. If you're on pain medication, sometimes it's better to just take the pain medication right before you do the exercise so that you're actually more comfortable and you can do more. And also that's a very good time to open up your lungs, prevent pneumonias, and get the breathing stronger.
Another thing I want us to talk about that we talk about often is the different medications. And I think what a lot of new people joining the community don't realize is the time delay in taking it and when these medications actually become effective, and the importance of taking it at the same time. And why it's important to also monitor your blood pressure while you're taking it, but not be, hostage to your blood pressure cuff. So if maybe you can talk to some of them and why we're put on certain drugs versus others who are on different drugs.
Sure. And again, this is one place where the gene testing may have a role. So for example, for people with the fibrillin gene mutation, which is a Marfan's gene, there is some data by Dr. Dietz who showed, at least in rats, and there are now studies being done in people, that the angiotensin receptor blockers, losartan or irbesartan, actually make the fibrillin gene byproduct. So irrespective of the blood pressure, we try to get one of those two drugs on board as much as people tolerate. But we try to get pretty good doses. And many of our Marfan's patients, because they have weaker collagen and relaxed vessels, often have very low blood pressure. So we're actually trying to get the medicine in them even with normal blood pressure.
Okay.
For people with higher blood pressure, we always try to use the beta blockers or angiotensin receptor blockers because they decrease the wall stress on the vasculature. So if you're going to help a dissection or aneurysm or help prevent them in other areas, those two classes of drugs, the side effects are to decrease the stress against the walls. So it's actually a wonderful opportunity to get a secondary benefit. And many of the things we try to pick with the medicines are, number one, we need the pressure controlled. Number two, we want the best secondary benefits we can get. There are other medicines that by themselves can actually increase wall stress, one of which is hydralazine. Hydralazine is a good blood pressure medicine, but it can cause increased wall stress, and it can cause reflex tachycardia, and it can increase the rate of aneurysm or dissection unless it's being used with the beta blocker. So there have to be combinations, and you don't just want to substitute without talking to your doctor, because they should be thinking about which combination is going to give you the best outcome and the least pressure against the walls of your vasculature. The medicines all have different half-lives, so some of them last 24 hours, some of them don't. Some of them have their peak effects a couple hours after the dose, and some, like amlodipine, maybe 6 to 10 hours after the dose. So you're really looking to try to have good average blood pressures and not treat every number. One of the biggest mistakes is to do things like you get one high number and you take clonidine and it bottoms out, and then you skip your next medicines and then you're too high. And when you do that, you end up with numbers that aren't controllable and this terrible cycle of events that actually increases your risk long term. So it's much better to figure out when your spikes are, change the timing of your medicines to cover those spikes. So sometimes changing the timing to nighttime or morning time or 2 p.m. can actually cover when your circadian rhythm spikes. Most people, despite being rested and feeling good, have their highest blood pressure first thing in the morning. So many of the recommendations are to take blood pressure medicines at night to better cover the morning so that you get more of an effective dose in your system when you have that peak in the circadian rhythm. So blood pressure cuffs are very good. You should use your higher arm pressure if you have a difference in your arms, because that's what your brain and heart are seeing.
Okay, and what would be considered a difference where you should be concerned? Because you're going to have differences between them anyway.
So you should know, no, most people are the same in both sides.
Okay.
If your vessels are the same to both arms should have about the same pressure.
Okay.
If you've had a tear where there's limited flow to one arm or the other, usually the left arm may have a lower blood pressure to that arm, and that does not reflect what the rest of the body is seeing.
Ever knew that. Learning something new. Okay.
Good.
No, I'm now going to start doing it in my other arm. Okay.
So every so often you can make sure your arms are equal. If you've had a tear and your arms are not equal, you want to know what the difference is. Okay. If all of a sudden there's a bigger difference, then we're more concerned.
Okay.
Or if the arm with the lower blood pressure, if it's too low, like less than 80, or it falls asleep when you're moving it, then the blood pressure to that arm may be too low and something may have to be done to improve the flow to that arm.
Okay.
But that doesn't reflect what the body is saying and the medications.
So if you end up having a little difference, you want to go with the higher arm.
You want to go with the higher arm is what
body.
you're following, because that's what the head and the heart are seeing.
Okay.
And you're going to do your medications around the higher arm.
I love learning something new every time I come in.
You come up with good topics.
I know. I just think pops into my head. I'm just checking to see if we've got questions. We have a lot of communities, just people saying hi. Okay. What information does a cardiac CT scan with contrast provide versus an echocardiogram? That's a great question, and I want to talk about MRAs too.
Yeah,
and
sure.
Why contrast versus no contrast, radiation, no radiation? Just explain the different tests and what they show.
So that's actually a great question. So first of all, the echocardiogram is focused on the heart. So it shows us the heart pumping function, the structure, the valves, specifically the aortic valve here, and the pressures in the lungs coming backwards. So often you can get an estimate of that. You see 4 or 5 inches of the ascending aorta, and then you want to make sure that they get a picture from here, the suprasternal notch. So not every echocardiogram actually takes a picture from here.
Only Corinne's the only one that's ever done it. Moves the pillow down, my neck is stretched like this, and she
for
does it
somebody
right
with a bicuspid valve or somebody with aortic disease, you always want to say, I need that picture from here.
Right here.
The picture from here is going to look at your arch, and they can see generally most of the arch and a little bit of the descending. Occasionally, depending on body size and shape, you can't see very well. And occasionally, if somebody, especially if somebody has underlying lung disease or air in the lungs, like immediately after surgery, occasionally you can't see the ascending very well. So you get about 4 or 5 centimeters of the ascending. Where the bronchus crosses, you can't see. Echo can't see through air.
Okay.
So you have a little gap in what you can generally see. In kids, you can see the whole thing. In adults, it's rare to see the whole thing. You can probably see about 70% of the thoracic aorta, and you can see if it's splaying or if it's really like the same diameter going up. If it's splaying, so that as you get to the top of your field, it's widening, you really need another imaging modality to see the aorta better. But you get the heart structure, you see it in real time, you see the function and the pressures and the valves.
And what are they seeing when they go down low, like underneath the diaphragm?
So they're actually looking up at the heart. They do see about 2 to 3 inches of the abdominal aorta. And again, if you're seeing splaying, you know you need another study, but you are not screening the whole abdominal aorta, just a little piece of it.
So really it is good for valves and the actual contents of your heart, the anatomy of the heart, number one.
And the pulmonary pressures and a good part of the aorta.
Good. Okay.
Your MR or CT is going to actually show you the areas outside of the heart better, and they can be gated to look at the heart, but that is a whole separate study.
Okay.
So the MR and the CT often do not see the heart structure and function. They see the areas outside of the heart, like the vessels, better. The CT may be the clearest picture of the vessels with contrast. The CT, though, has dye and radiation, and some people are allergic to the dye, and some people are really allergic to the dye.
Yeah.
And some people have had a lot of scans and radiation. So that's one consideration of how often should you do the CT and what are your specific risks of dye and radiation. So radiation, we're looking at the cumulative dose, and the dye is an iodine-based dye, so we worry about contrast allergies, and also if you have underlying kidney disease, it can affect the kidney perfusion. If your kidneys are normal, it's actually fine for the kidneys. And pre-hydrating before the CT scan with contrast is very protective for your kidneys. Okay. So that's actually the most important time. It doesn't matter so much what you do after, it matters what you do ahead of time.
So drinking a lot before.
Drinking a lot before is actually really important and helpful. The MRI or MRA is what you would be using, the MR angiogram. So the A is angiogram, meaning it is vessels themselves. Okay. And there's some sort of shadowing or dye that's looking at the vessels. The MR angiogram uses a different contrast called gadolinium. Gadolinium does not have the same risks to the kidneys. If you're a pre-dialysis patient, it can affect the kidneys. It doesn't affect the kidneys, but it can actually be stored in the muscles and very rarely affect the muscles. So we don't use gadolinium in people that are pre-dialysis, but it is actually easier on the kidneys, and the effects and allergic reactions are extremely rare. So it's mainly an inert substance.
Just takes longer.
It takes so much longer because it's reading your body's magnetism. So it takes a while for everything to line up and for it to be able to read the magnetic impulses from the body. It gets very good images. It can be clear or more clear than the CT, but it takes a long time, and it has a lot of movement artifacts. And if you're claustrophobic, it can be hard because it's more of a tunnel, and it is loud and clanking. It has less risk, no radiation, and less risk to the kidneys.
So I would say if your surgeon if you've gone through your year, it's something you could bring up with your surgeon to ask. Because it ultimately, while it takes longer, it's probably better for you.
Right. So the CT is going to be a little more clear. So if you're looking for very subtle findings, and if you need a quick scan like you're having active pain, the CT really is the gold standard and is better. The MRI is going to take longer. It would slow down an emergency. But if you're doing serial scans, it's a great way to actually confirm or follow or do a repeat scan and take out the radiation from the CAT scan and minimize the number of CAT scans. The other thing is the echo, you at least know what you see and what you don't see for certain people. So for example, if I have Ehlers-Danlos patients that are doing screening, many times we see most of the aorta. So we can do many of the patients with echo and abdominal ultrasound and not really need a CT or MRI, or maybe every 3 to 5 years we'll get a CT or MRI. Vascular Ehlers-Danlos patients, I would still do some sort of better imaging every year and include the brain. But a hypermobile Ehlers-Danlos patient, the type 3, has risk of dilation and aneurysm, but much lower than a lot of the other groups. And the aneurysms are generally in the larger vessels, not in the brain. We don't actually recommend routine brain screening, but we do recommend some sort of visualization of the aorta. Often in that population, you can do it all with ultrasound. But if you can't see, you really need to get a better study like a CT or MR. And really the findings are going to be equivalent because you're looking at the size and shape, and you're going to see well enough to see any of that. It's when you're really looking for a tear that the CT is better.
And then you also want to make sure you go to the same facility every time, right? You want to try to always have the same machine or
same facility or one that they can actually compare. Or if you're moving, for example, and that's not an option, I don't think that's as important that you fly back to the same radiology facility, but you should get the disc, and you should keep the disc and maybe let your doctor download the disc, or certainly if you have a problem and the surgeon needs to keep the disc, let them keep it, because you can always have the radiology center send you another one. But at the same time, try to keep your disc and bring it from place to place and make sure the radiologist has it, so they can actually put them side by side and superimpose it and see if there really is a change, because you're comparing ovals.
Okay. Let's see. We're still talking about cardiac rehab.
Yeah, and the cardiac rehab, again, I'm seeing people that were offered, could do it, couldn't do it. There is a phase 3 cardiac rehab that somebody may be referring to. And hi, Pam. I love Pam. So phase 3 cardiac rehab, sometimes if you don't qualify for phase 2 and you don't need physical therapy, phase 3 is what the rehabs offer for people that have completed phase 2. So you're actually at the rehab They can't offer you being hooked up on the heart monitor. They can offer to check your blood pressure here and there. They can help guide your exercise, but you exercise at the facility where the nurses and physician are. And it may be a safer way to start, and generally it's very affordable.
Okay. Do you recommend for anybody who has an aneurysm or has a bicuspid valve and they're going to be having surgery to do any type of exercise to help build stamina before, or can they exercise before? And if so, are there weight lifting restrictions or exercise limitations?
That's actually really important. So number one, we don't want to enlarge the aneurysm. And number two, we don't want you to be the ticking time bomb, right? If you're a ticking time bomb, it should be fixed. So that's important. Your doctors, if you're under surveillance for them, they shouldn't be pushing you, and won't be pushing you to the point where you're expected to rupture. The things you can do is, we really like for people with known aneurysms or a history of dissection, minimize the weight. People will have different weight restrictions. There's not perfect guidelines. There is actually a Texas exercise program, research program going on with Dr. Prakash for people with no. Okay, good.
Yeah.
So that's actually, maybe that will actually help our recommendations. In the meantime, I personally generally recommend 35 pounds or less as what you're regularly lifting. So you can use different arms if you want to do higher weights. So, for example, I had a guy that is currently in the FBI that we were able to get through that has a moderate aneurysm with a bicuspid valve. He was 22 and he went into the FBI. He's around 40 now. I don't want to date myself, but and if he's listening, hi. But basically the aneurysm has been stable. When I met him, he was bench pressing 300 pounds regularly. He didn't know he had an issue. I gave him a 35-pound weight restriction, and you would have thought he was, done.
Took away his whole life.
At the same time, what he does is he does 35 pounds in each arm, one arm at a time or one leg at a time, and he has the same physique and fitness. He just has to do a lot more repetitions. Where most people would do 5 or 10 pounds in each arm, and then you can either do them in the same arm. You can help do things like move furniture, but you need a few people, right? You're not going to just move the couch yourself. If you're moving, that's really the time to look at getting help or having friends and family step in. You do want to be really, really thoughtful about being able to have that short sentence during your exercise. So if you can speak a short sentence during your exercise, then you're breathing easy enough to do that. You should exercise with aerobic activities. Rowing, swimming, tennis, bicycle, all of those are really good things.
Can you do sit-ups when you've had a dissection or you've had, if you're exhaling,
again,
can you?
Do better with things like planking, because sit-ups, you're going to, people tend to do the crunches where you're really holding your breath and pushing down. So that's not the best thing, but where the planks are very strong resistance, you work the core very hard, you can get the same abdominal definition, but you don't have the strain.
That bearing down.
That bearing down, holding your breath, that's what we want to get rid of. Right, so that's called isometrics, and you want to do the aerobics, the steady heart rate increase, continued aerobic activity, fat burning and toning, but not the straining.
Right. We're in the middle of summer. We've got 2 things I want to talk about before I check for more questions. This heat has been disgusting. It's so oppressive. It's so hot. And I don't know about everybody out there, but I find that the extremes, whether it's heat or cold, are just killing me. I'm fatigued. I feel like I can't catch my breath. What are your thoughts about how we're supposed to manage in the extremes of heat or cold?
So, extremes are hard for anybody. I think with dissection, unless you're talking about something else going on, like dehydration, if it's hard to eat or drink, that's different. If you have GI issues, that's going to be where you're most vulnerable. But from a dissection standpoint, the relationship may not be as strong.
What does dehydration, what can that do to your blood pressure?
it can make it very low.
Mm-hmm.
So it can make it low. It also can make postural symptoms worse. So
Okay.
if somebody has postural tachycardia or postural hypotension, which a lot of connective tissue patients may have, that's about a third of patients with Ehlers-Danlos and many patients with Marfan's that may have postural hypotension because the vasculature is weak. So everything pools.
Mm-hmm.
And when you stand up, everything's pulling, gravity's pulling it down, and you don't get enough to your head. So the heat can make your vessels dilate.
Mm-hmm.
They make it relax, dilate. The pressure generally drops. So you actually need more fluid in your system. Sometimes you need a little more salt in your system, and that's going to be individual. If somebody has heart failure or kidney problems or a high blood pressure, you don't want the salt.
Okay.
If you have low blood pressure, it may be counterintuitive, but with low blood pressure, you need the salt to maintain your blood pressure. So I think you have a very mixed group of people listening, some who may have very, very high blood pressure and some have maybe very low blood pressure. And you really do have to balance your blood pressure and your fluid intake and your salt looking at your heart and kidney function.
Mm-hmm.
But from a dissection standpoint, your vessels want the lowest blood pressure they tolerate, but some, right? Not none, some.
Right. Some.
You don't want to be dizzy.
Right.
You don't want to feel dizzy when you stand up. The extreme cold is going to make you have a higher cardiac output. You're going to have to, your heart and vessels are going to have to squinch down and work harder to get enough out to all the
That's
systems.
when your pressure can go higher.
It can go much higher.
And it's going lower in the summer.
For the most part, right? Unless you have heat exhaustion. But everybody is susceptible to the temperatures. And I know somebody was asking about altitude. I just happened to peek the other day.
That was the other day, yes.
Yeah, and that was a great
question.
You
told me, you said people live in high altitudes with dissections and aneurysms, so you said I could go if I wanted to. It wasn't going to be bad for me to do that.
Yeah. Right. Now, if you've had lung injury, that's different, right? If you've had lung injury or you have high blood pressure in the lungs, so one example of aneurysms may be Behçet's disease. So Behçet's disease, people get little vascular malformations, they get lung and kidney issues. And, you can get these vascular malformations and high blood pressure in the lungs that make you very susceptible to altitude.
Okay.
Or somebody who has a blood disease that has a very high level of hemoglobin. But that's not this group. That's not dissection patients. And there's enough issues. We don't want to create issues that you don't have to have.
Right.
Yeah.
So going back to one thing real quick, there was a question asked on another page that I was a part of. The question was, can you eat or drink before you have an MRA?
Absolutely. It's nothing to do with it. Unless you're looking at the bowel. So if you're doing an MRE of your bowel, then they're going to have a bowel prep of some sort. And
that's what you get to eat or drink.
That's what you get to eat or drink. And outside of that, it doesn't affect anything. And the same with your CT if you're doing the aorta. And the same with an echo.
Okay. So speaking of summer, rides at an amusement park. I just texted Dr. Fisher this a week ago. I just arrived at Busch Gardens, and as I'm leaving the car, I asked, can I go on the log flume? I haven't been on a ride other than the WIT with my sister for 4 years. And you said, yes, go on the log. Please, yes, go on the log flume. So,
but I also said not the
roller coasters,
because of the sheer stress of the push and pull.
Right, but you could go, we had a nice hill, and I was a little nervous, but it was really wonderful to go down. But that doesn't really create any G-force, and that's, not like it was when I was a kid. So you can go on some rides, but not the things that spin or G-force or stuff like that.
Yeah, so. And generally the things that say don't go on if you're a heart patient, I would look at those things.
Right, and just don't go on.
Yeah, but use your sense and use your own understanding of your heart health. And, again, some people have been totally repaired. So if you have a bicuspid valve and you had an ascending and nothing else is wrong and that's been replaced, you may be considered back to normal.
Right.
So this is a personalized conversation as well. If you know that you still have a persistent, dissection, then, and you're torn all the way down, you need to be much more careful than somebody who's been replaced and reinforced and doesn't have risk for other things.
Right.
So, it is something that you should actually talk to your doctor about. I see someone that says minus 4.3 and scared to death. I'm not sure if that's ascending or descending. if there's anything like a genetic issue or a different reason for it, if it's a bicuspid valve. 4.3 and Marfan's is more concerning than 4.3 in like a bicuspid aortic valve, where it could stay that way for years. So again, it's important to look at why you might have a aneurysm or dissection, what happens in your family, what the underlying makeup of the connective tissue is. And again, if you're a ticking time bomb, then it needs to get fixed. Right. 4.3 is not generally a level where we would fix it. And what you want to do is try to keep that lifting to around 35 pounds or less. Do the aerobics instead of the isometrics, and you want to be active. Right. Because activity is going to help you from, mental, physical, vasculature, orthopedics, prevent plaque. You don't want plaque added to weaker vessels.
And the reality is, when I saw that I've dissected, when I saw that mine was growing, I decided to stop all exercise for about a year, thinking that it would keep it from growing. And the reality is it's not going to necessarily stop it from growing. If it's going to grow, if you have an issue with your tissue, it's just going to happen. Right. So while I thought I was preventing it, all I did was set myself back on stamina and stuff like that. So, but again, that's a good personal conversation. And how do you get the radiologist to complete measurements? I'm not sure.
So you're saying, so I think I know what you're asking, because sometimes you get a report and it doesn't have any of the numbers on it. It'll just say mildly enlarged or moderately enlarged. It can be really frustrating. I personally have had to call back the radiologist, or we generally get the scans, the films. Most of the films, when you bring them up on a computer, they're on a reader and you can't do the measurements and they may not have the scale. Generally, we can load them into the programs on our readers, and actually the scale will come up and you can do the measurements again. And it's really nice to have the radiologist that's reading your current film look at your old film and make sure the measurements are in the same place. But you can call back to the radiology place and say, look, I'm an aneurysm patient. I've been followed for aneurysm at my sinuses, and I'd like to know the number. And they'll usually measure it and revise the report.
So one said that Nicole had mentioned that one location where I guess she had testing gave very specific measurements and the other one only gave one. So could you call that secondary place back and say, could you give me the whole list of measurements for everything?
Yeah, but there's no defined list of what everything is. So you may want to say, like, can you compare this to my old one? Here's the report, or here's the disc. Okay. You could actually be very proactive and take the disc there, or you could actually get the disc from the radiology place as you're leaving, take it to your doctor, and have them measure it at their radiologist or their place. And it is a good idea if you have the option to actually do the test where your doctor is, because, for example, if I had someone, it took me 2 weeks to get the report back to them, and I felt horrible. They did it at an outside radiology place closer to their home. The report that I got, which I got the next day, said mildly enlarged aorta. No pictures, no numbers, no anything. So I call her and I say, I have no idea what this means. We've requested the disc and it should be getting shipped here. It took about a week to come. I had to take it downtown to our reader because none of the regular readers would actually play it. So I had to take it downtown to our reader, get it loaded up. One of the engineers figured out how to get the disc read. It wasn't something that just worked well. And if she had just gone to our center,
in the hospital, you would have had it.
I would have had it. I could bring it up. I could measure it. I could compare it. I could give her the results in 10 minutes. Yeah. Where, here it took me 2.5 weeks and she was very nervous. Yeah. So if you have good stamina and there's either a cost savings or a physical time savings, that's fine. But there could be a delay in getting the results because the results aren't clear, because they don't all report the numbers.
So Lisa's asking real quick, well, Charlotte said she thought it was no more than 10 pounds, but you had said no more than 35. And Lisa's saying she does bodybuilding, so is it 20 pounds max in each arm at a time?
And that's what I'm saying. This Texas study may help give more consistent guidelines. What I told you is what I tell my patients. and it seems to go very well. And I think people stay in good shape and don't have any complications or side effects of the exercise. 20 pounds in each arm should be perfect, right? And again, if you have, like my FBI guy who was doing 300 pounds and goes up to 35 pounds, it's much better and really a good number. If you are lifting a 30-pound baby, for example, which ends up happening, I really do think 35 pounds is a good regular cutoff for what you can regularly lift. And you should be in shape if you're lifting 35 pounds. You don't want to go from nothing to 35 pounds saying Dr. Fisher said I can do 35 pounds, and you're 85 and 4'8" and have never lifted 35 pounds. Right. So using some judgment, 35 pounds is a good number. Many doctors will give different numbers. There's not a scientific basis for the number, but the idea is that you're doing everything aerobic and not straining. If you feel like you're holding your breath and straining to lift something, then it is too heavy. And if it doesn't feel heavy at any of these weights, then 35 pounds is still your cutoff.
Okay. Somebody had asked how you define phases.
Phases of cardiac rehab or phases of...
It's a good question. It wasn't specific. It just said, how do you define phases? I didn't know if you knew what that meant.
I talked about phases in the context of cardiac rehab. So phase 1 cardiac rehab is in the hospital, and the phases are defined by insurance.
Oh, okay.
And the programs have followed that definition.
Okay.
So phase 1 is what you do in the hospital as part of your recovery, and it will continue in inpatient rehab if you need it. Phase 2 is the outpatient program that physically includes 36 sessions of cardiac rehab exercise, 1 intake session where you get to know them, you come up with your goals, generally a session with a psychiatrist that concentrates on having cardiovascular disease and dealing with the implications of cardiovascular disease, which is wonderful because everybody has a mortality effect. Just dealing with mortality, dealing with this massive change in life and life quality and potentially life expectancy and the suddenness of the change. So it's wonderful to have that opportunity. And then generally also includes 1 meeting with a nutritionist.
Well, I'll tell you what your rehab does at Upper Chesapeake, part of University of Maryland, did exactly everything that Dr. Fisher said, but every week we had somebody discuss nutrition and lifestyle every day. Every Thursday I'd go in, and so while you're on your treadmill and you're trying to get to 6 minutes or 8 minutes, they had a whole slide presentation and would teach you something else, or why you should try to stop smoking, or just a variety of different lifestyle changes in nutrition. It was very informative.
And that is optimal, and I know St. Joe's does that too. LifeBridge, they have a person talking. I don't think they have slideshows, but not everywhere has that. And what should be included is what I said. That's what Medicare actually will generally pay for and cover. So the programs try to include that, and then they can certainly do more and throw in more. And they have, they want good outcomes. They want people to do well. Phase 3 is after you've completed the second really truly monitored phase, when you want a safer environment for exercise, but you're really doing your own program or continuing what you've developed in phase 2. And again, part of what you're getting out of phase 2, what I think is the most important part, is that you develop a program that you can then take with you and continue to do over time.
One important question that's on here that we've talked about before, which is how can you recognize aortic pain compared to stomach pain, chest pain, or as my colleague Greg will laugh at me, gas pain, which I always say everything's gas. How do you know when it's aortic related? A lot of people want to know, how would I know if I dissected? And I don't think there is one general answer, because there are people who felt nothing. There are people who feel like a gas bubble. There are people who feel like they're tearing. How do you know when it's time to go to the ER?
Yeah, so it's a very hard question. So number one, if you're not sure, it's better to go to the ER and get checked out, especially if you have a known aneurysm or dissection or strong family history. And if you feel strong enough to go to the ER, you do not want to leave without some sort of imaging, because it's really, the person interviewing you may not be able to tell better than you can.
Right.
The EKG or blood pressure may actually not show it.
Mm-hmm.
But at the same time, there's a lot of anxiety that comes with having had a dissection or having an aneurysm, and you don't want to get overscanned. So we try to have some sort of balance.
Mm-hmm.
So if in fact you have something that goes away with the belch, or really you have a burning sensation and bile taste in the back of your mouth, and you try an antacid and it makes it get better, it's okay to say I had a bout of heartburn. If in fact it hurts when you push on it, especially if it's in your incision site, or you've strained something and you're trying to figure out, is it something I tore, or did I lift too much, am I just sore? If you push on it and can reproduce the pain, that's not going to be a tear inside.
Okay,
right?
That's good to know.
If it is something that comes for a fleeting second, like an electrical sensation, and happens at different parts of the chest, everybody has some of that, right? The other thing is, generally, if you take a deep breath and it hurts at the end of the breath, that's going to be more the lining around the lungs, so you'll feel that more with something that affects the lung, like an infection, a bronchitis. So are you sick other ways? Are you feeling tightness because of asthma? If so, does your asthma medicine fix it? So it's okay to take a few minutes and figure out, can I make it better? Can I try an antacid? Can I try a Tylenol? Does Bengay or lidocaine patch take the discomfort away? Does it change when I get in a better position? Because a dissection isn't going to get better like that. It's just going to stay painful.
I know these rules. They're embedded in my head because I'll text you often.
Yeah, so I would start with the 1 minute rule.
Right.
If it lasts less than a minute, you're okay.
Right.
If it is coming in a pattern with exercise and taking your breath away and making you exhausted, you want to get your coronaries checked, right? If it's something that is a persistent discomfort, often people describe like a toothache-like pain or aching, penetrating discomfort, you just go right in and get checked out and don't leave without the imaging. If you find out that it's gas, wonderful. We'll all be really happy. And again, we'd rather you get checked out than miss it, but we also don't want to interrupt your lives sitting in emergency rooms all the time. So those are a few things that may help you discriminate.
Some of these people are talking about that they've had restless legs since they've dissected. Is that
and not
something you've
before
heard about?
they dissected, or
not mentioning that?
Yeah, so I don't know that that's directly related to the dissection. Restless legs are something that can happen. Certainly the muscle cramps or muscle pains can happen. Magnesium would be the first thing to try for that. That's actually what we give people also in pregnancy for muscle cramps. That's over-the-counter magnesium oxide, 400 milligrams a night. Does not affect blood pressure at all. If anything, it can lower blood pressure. It can certainly make the bowels a little bit more active. So that's something you want to be careful of. But magnesium would be the first thing for muscle cramps. Restless legs is different. That's more of a neurologic finding. There are treatments for that. The other thing that you want to look at for that might really help some people here is iron deficiency. So iron deficiency can happen from surgeries, can happen from, heavy menses, can happen from blood thinners related, to therapies, and then people may have nosebleeds or heavy menses or bruising. So iron deficiency can cause restless legs, so you could get your iron levels checked. If you're soon after surgery and your blood counts are low, just take the iron. And that may fix the restless legs, because that's probably one of the primary causes.
If you have any other questions, you want to start typing them in now, because we're just going over 7. We're going to go for just a few more minutes. But so somebody said they had an emergency AD, tore into both carotids, type A, elephant trunk. Can they still lift weights?
So the answer really is no. You can do the light weights, lots of repetitions. I gave a guideline that I give up to 35 pounds. Other people are saying they've been given up to 10 pounds. Some of it is doctor dependent. Some of it may depend on what your residual disease is. So if everything's replaced and your entire arch and vessels are totally replaced, they may give you up to 35 pounds. If you still have tears that are very fragile, you may want to keep it at 10 pounds.
Okay.
So you do want to talk to your doctor about the number. At the same time, there's not any data between 5 and 30 pounds.
Okay.
Right? At the same time, 50 pounds or more, we know that you're going to really be straining, bearing down. The shear force is higher, the blood pressure spikes up, and that's too much.
Okay.
So somewhere in the middle is going to be right.
If you were never granted any type of cardiac rehab or ever did PT, and it's 5 years later, and you're still feeling the after effects because you're just not who you were before, do you think that would a cardiologist be willing to write a script for PT just to help somebody get their stamina back and at least have some monitoring?
So PT is not an exercise or stamina program.
Okay.
I mean, PT really is focused on a particular part.
What about cardiac rehab? Could you have that 5 years later? Probably not.
You could, if you paid for it. It's
Right.
not going to be covered,
Okay.
right? So some sort of low-level conditioning program, because at that point you're going to have your blood pressure controlled, your heart rate controlled. You may actually want to consider like a low-level conditioning program with a trainer.
Okay.
With the restrictions given by your doctor, you could try swimming, but something where you always warm up and cool down. Some areas may have wellness programs. There's actually an aqua therapy program in some of them. That may be a great option. But some sort of warm up and cool down. The other thing is to make sure you're not having side effects of your medications, that your medications are optimized, that your sleep hygiene is good, that you're not having pain that's untreated, because those things can really be exhausting and make you feel bad.
Okay.
But 5 years out, you should be recovered from any of the surgical things, and you really are treating underlying conditions.
Tammy, hey Tammy, my new friend that's found out she's not far from me. So she requested an echo in the ER but was declined and was told she could only have an echo if she was admitted. And then 8 days later they realized she had dissected.
Oh, that's terrible.
Yeah.
So they may not have nighttime echo availability, but they all have CT or MR. And the issue was, they must have had an erroneous low suspicion to look for dissection. So the thing is, if you have resolution of the discomfort, they're going to push it off to outpatient.
Right.
If you have a known aortic aneurysm or dissection or family history, you really can say, look, I'm uncomfortable because I still have some residual discomfort, and I know I have this tear. Can you do any imaging? But don't demand a particular image. Have a conversation with them. The minute you start dictating a particular image, they're going to feel defensive, or they may have been in a position where a lot of people are come in demanding things that aren't indicated. It is fraud for us to do things that we don't have a good indication for.
Okay.
So you have to have a conversation. What does your center have that you could see that I'm okay or not okay?
Okay.
And again, if you're looking for aneurysm in the emergency room and you don't have a contraindication, the CAT scan is going to be your best buddy.
Anyway, right.
So they're probably saying, well, we don't have an echo tech, your pain's all the way gone, and you could do this outpatient. And I don't see a reason to radiate you for the CT, where if you say I still have this dull discomfort and it's why I came in, I've never been in before, you may actually have what you need to have.
Okay.
So try to have a conversation with the emergency doctor where you're letting them lead your care, but you're leading them in the way you want your care.
Okay.
And if you're really not getting what you want, you may want to call your primary care doctor and just ask, or your heart doctor, or whoever you've been working with, and say, can you discuss this with them? And like a lot of times you've called or sent me a text, which you can't do with most doctors.
Right.
And I can't do with all of my patients, but we try.
Yeah.
But you have let me know that you're going to the ER, so you can call the answering service of your physician and say, I'm going into the ER. Can you tell them ahead of time that I have an aneurysm and that I'm having chest pain so that I get brought back? I'm not waiting in the waiting room. And can you help come up with the imaging that we'd like to have?
And that's a really good point. So I have gone to the ER quite a few times since my dissection. And the couple of the lessons I've learned is, well, one time I had a hospital stay and they wanted to do a stress test. And I called you right away and you said, we're not doing a stress test. And you told them no. And another time they did.
Right, but they didn't have your information either.
No,
so to
no,
know
they didn't.
that, yes, you've had a heart cath,
Right.
you also had a CT at this
Right.
place some other
Yeah.
time. Here's everything together. And if we look at the whole picture, I don't think that's going to be helpful, but this might be really helpful.
Well,
or
they also,
maybe we could try these things this time. And
they also freaked out because my scan said I had an aneurysm at like 4.8. And I learned subsequently, let them freak out. This is what you guys see every day. You're the catcher's mitt. And if you're not freaking out, then there's no reason to let anybody else freak me out. That whatever they say, but they have to pass all information through you. Like you're
Right.
the top dog at the top of the chain.
Well, and there are people that are transferred over to our center by helicopter where the measurements are erroneous, or they're remeasuring something that's been stable for 15 years. And, we're very careful not to just take someone to the operating room until we've confirmed everything about the aneurysm, and whether or not you really need to do something operative, or if there's something non-operative or catheter-based that could be done, even if it's a little bit of time. If it looks like you have the time, it's better to take the time and have a less invasive outcome.
Right.
So it's okay to have those conversations too.
So the final question, and then we're going to wrap it up, but I'm going to mark where we left off so that Dr. Fisher can come in and answer any other questions on here when she has a moment. Rosemary said, who's a leader in aortic aneurysm care? Which would be hard to answer not knowing where you are or where to give you that advice. But how do you know when it's time to have surgery? She has upper and lower aneurysms. One is a little over 5.
So again, I don't know where you are. There are many good centers. Ours is University of Maryland, and we have an aortic disease center. Dr. Brad Taylor is the cardiothoracic surgeon. We have a hypertension specialist, Dr. Wallace Johnson. Our geneticist is Dr. Carol Green. I do the cardiovascular parts of it, and Dr. Tor is our vascular surgeon. Tor Savakis.
Could very well be. I haven't had to say his name yet.
Dr. Tor is wonderful. He does have a long name. But if you look at the Maryland Aortic Disease Center, he's fantastic. Other good centers, include Mayo, include Cleveland, include Duke, for example. But you want to look at what you have and what's happened. At the same time, there's a huge mortality benefit in the dissection to getting in as fast as possible. And then you want to talk to the center that you're at about who in your region has the best outcomes, and you want to see if they're available, because you have to get done immediately. So you want the surgeon that has done the most, that is the most comfortable in an emergency. Electively, you have time to actually research this. You can even go for opinions. You can talk to this community who's very astute and say who really had a good outcome, and what do you know about these people, and you'll probably get a lot of names, and who's closest to me, and who does my insurance cover. So you want to look at all of those things, because there is good aortic surgery. The thing that is newer is that there is a lot of intervention for aortic disease through the catheter that is not available everywhere. And if you have the opportunity to have TVAR interventions, which is the catheter-based interventions, you may be up and running around the next day with no recovery and no rehab needs, rather than recovering from a major surgery. So that's something you want to ask about. Am I a candidate for a catheter-based approach based on my anatomy? Right.
Okay. All right. Well, now that I've kept you till almost 7:15, we will probably have Dr. Fisher back in September during Aortic Disease Awareness Month, because it's such an exciting month, and it's a great time to start forming some more questions and topics that you, the community, want to hear about. So if you start thinking about that, we'll be asking you about that soon. So thank you again so much.
Thank you, Karen,
for staying late in your busy day.
You're welcome.
And I got to see you twice this week, which is so exciting.
It was nice for me.
Good. All right, everybody. Thank you so much again. Don't forget to put any questions you have and Dr. Fisher will try to peek over at some point and try to answer some of those for you. So thank you again, guys, so much, and we'll see you with another one of these in a month. Take care.